Mr. Thomas is a 58-year-old male who is attending a cardiac rehabilitation program after having undergone a coronary artery bypass graft (CABG) surgery. During his rehabilitation, he is performing an exercise treadmill test as part of his assessment. After a few minutes of mild intensity walking, he begins to feel chest discomfort and his heart rate reaches 135 bpm, at which point his blood pressure drops from 140 mmHg to 110.7 mmHg. What is the most appropriate immediate course of action in this situation? Answer: in this scenario, Mr. Thomas is presenting with symptoms that suggest he is experiencing exercise-induced angina and possible hypotension. According to guidelines from the American Heart Association and the American College of Cardiology Act, the following actions should be taken. Discontinue the exercise immediately to prevent further strain on the heart. Monitor the patient closely. Continuous ECG telemetry should be used to assess for arrhythmias, which are common in post-CABG patients. Reposition the patient. Help him into a sitting or supine position to reduce the effects of hypotension. Minister oxygen if necessary, especially if there are signs of hypoxia or oxygen desaturation. Assess pain. Chest pain should be evaluated for its characteristics e.g. duration, quality, and treated accordingly e.g. with nitroglycerin if ischemia is suspected. Prepare for emergency response. If symptoms persist or worsen, prepare to activate a code blue and initiate advanced cardiac life support (ACLS) protocols. What is the primary goal of functional capacity testing e.g. the 6-minute walk test in cardiac rehabilitation, and how does it influence patient care? Answer: the primary goal of functional capacity testing, such as the 6-minute walk test (6MWT) in cardiac rehabilitation, is to assess the patient's ability to perform physical activities and their overall exercise tolerance. This test provides valuable information regarding the patient's cardiovascular and muscular endurance, and it helps quantify the level of functional impairment caused by heart disease. Key points: patient assessment. The 6MWT provides a reliable and simple assessment of a patient's functional status, which is particularly useful in patients with cardiovascular disease as it directly correlates with their ability to perform daily activities. Guiding treatment decisions. The results of the 6MWT can help rehabilitation professionals to tailor exercise prescriptions by determining the patient's baseline fitness level. The test may also help in identifying the need for further diagnostic tests if the results suggest a significant reduction in exercise capacity. Tracking progress. The 6MWT is repeated over the course of rehabilitation to assess improvements in functional capacity and endurance, which can serve as a positive reinforcement for patients and a way to track the success of the rehabilitation program. Prognostic indicator. Studies have shown that the distance walked during the test has prognostic value. Shorter walking distances have been associated with higher morbidity and mortality in cardiac patients. Guidelines. The American College of Sports Medicine (ACM) and the AHA recommend functional capacity testing as a part of cardiac rehabilitation programs to evaluate a patient's ability to engage in exercise and monitor their progress. The test is especially valuable for patients recovering from major cardiac events such as heart attacks or surgeries. What are the essential components of emergency procedures such as CPR and defibrillation in the context of cardiac rehabilitation, and how do these procedures align with current clinical guidelines? Answer: in cardiac rehabilitation, the ability to respond promptly and correctly to a cardiac emergency is essential. This includes performing cardiopulmonary resuscitation (CPR) and using defibrillation when necessary. The following components should be followed. CPR. Chest compressions should be performed at a rate of at least 100-120 compressions per minute with a depth of 2 inches 5 centimeters. Compressions must be allowed to recoil fully between compressions to promote effective circulation. Airway and breathing. If trained, provide rescue breaths at a rate of 2 breaths for every 30 compressions. However, hands-only CPR without rescue breaths is recommended for untrained bystanders. Defibrillation. AED usage. If the patient is in ventricular fibrillation, VF, or pulseless ventricular tachycardy (VT), defibrillation should be initiated as soon as possible using an automated external defibrillator aid. The shock should be delivered according to AED prompts. Timing. Early defibrillation within 3-5 minutes of arrest significantly increases survival chances. Unless Linda, a 72-year-old woman, is participating in a cardiac rehabilitation program after undergoing a percutaneous coronary intervention (ECI) for an acute myocardial infarction (MI). During a session, she reports mild shortness of breath, lightheadedness, and a feeling of fatigue. Their vitals show a resting heart rate of 80 bpm, a blood pressure of 125/75 mmHg, and oxygen saturation of 94%. What steps should the cardiac rehabilitation team take in response to MS? Linda's symptoms. Answer: MS. Linda is presenting with symptoms that may indicate exercise intolerance or mild decompensation. The cardiac rehabilitation team should follow these steps. Stop the exercise. Discontinue the exercise immediately to avoid further stress on her cardiovascular system. Monitor vital signs. Recheck her heart rate, blood pressure, and oxygen saturation to assess if the symptoms are due to hemodynamic changes. Assess symptoms. Ask MS. Linda to describe her symptoms in more detail. E.g., is the shortness of breath worse with exertion or at rest? Rule out other potential causes such as orthostatic hypotension, arrhythmias, or coronary ischemia. Administer oxygen. If the oxygen saturation drops below 90%, administer supplemental oxygen to ensure adequate oxygenation. Patient repositioning. Have her sit in an upright position to alleviate symptoms of lightheadedness and improve oxygenation. Reevaluate exercise prescription. After recovery, the exercise intensity may need to be adjusted to prevent recurrence of symptoms, particularly if they are related to overexertion. What are the key factors involved in evaluating patient-reported outcomes (PROs) in cardiac rehabilitation, and why are these measures important? Answer: patient-reported outcomes (PROs) are essential in assessing the broader impact of heart disease and rehabilitation on a patient's quality of life. The key factors involved in evaluating PROs include health-related quality of life (ATOCR). Measures like the SF-36 and EC5 provide insights into how the patient perceives their physical, emotional, and social well-being. These tools can help identify areas where rehabilitation interventions are needed. Symptom burden. Patients may report symptoms such as dyspnea, chest pain, or fatigue, which can inform clinicians about the severity of disease and the effectiveness of treatments. Psychosocial factors. Anxiety, depression, and social support can significantly affect rehabilitation outcomes. Addressing these factors is crucial for improving the overall rehabilitation experience. Functional status. PROS often measure a patient's ability to perform daily activities, which is important for tailoring rehabilitation goals and ensuring functional improvement. Importance. PROS provide a comprehensive understanding of how heart disease and rehabilitation affect patients' lives beyond clinical measures like exercise capacity. These tools are valuable for assessing the success of rehabilitation programs and for modifying interventions to meet individual patient needs. Guidelines. The AHA recommends using PRO measures to track the success of rehabilitation and to guide patient care. Regular administration of tools like SF-36 and EC5 can help clinicians understand patient outcomes and adjust treatment plans accordingly. How do changes in blood pressure during exercise testing, e.g., a significant drop in systolic BP, inform clinical decision-making during cardiac rehabilitation? Answer: a significant drop in systolic blood pressure during exercise testing is a concerning finding and can suggest several possible underlying issues. The clinical implications are orthostatic hypotension. A drop in systolic BP greater than 20 mmHg during exercise may suggest orthostatic hypotension, a condition that indicates poor cardiovascular reserve or autonomic dysfunction. Exercise intolerance. Such a BP drop could indicate the patient's inability to adequately increase blood pressure with exercise, which could be due to heart failure, poor circulatory responses, or myocardial ischemia. Severe coronary artery disease (CAD). A drop in BP may be indicative of worsening coronary perfusion during exertion, signaling the presence of significant blockages in the coronary arteries. Clinical decision-making. If a patient experiences such a drop, the rehabilitation team should discontinue exercise immediately, monitor ECG for arrhythmias and assess for any ischemic changes, reevaluate exercise tolerance to determine whether adjustments in exercise intensity or type are required. What are the challenges in ensuring long-term adherence to lifestyle changes, such as exercise and diet, following cardiac rehabilitation, and how can healthcare providers help improve compliance? Answer: ensuring long-term adherence to lifestyle changes is one of the biggest challenges in cardiac rehabilitation. Key challenges include behavioral barriers. Patients may face lack of motivation, depression, or fear of re-injury that hinders their ability to maintain lifestyle changes. Social support. Lack of support from family or friends can contribute to difficulty in adhering to rehabilitation recommendations. Complexity of recommendations. Sometimes the recommended changes, e.g., exercise regimens or dietary modifications, are perceived as too difficult or time-consuming. Physical limitations. Some patients may face physical barriers, such as chronic pain or joint problems, that make consistent exercise challenging. Healthcare provider strategies, motivational interviewing. Use of motivational interviewing techniques can help address patients' ambivalence toward change and increase engagement in the rehabilitation process. Goal setting. Establishing realistic incremental goals allows patients to experience success and build confidence in their ability to make long-term changes. Support systems, engaging family members and caregivers in the rehabilitation process can provide additional social support. Education. Ongoing education about the importance of lifestyle changes and the health risks of non-adherence can reinforce the long-term benefits of rehabilitation. Guidelines. The ACC and AHA emphasize the importance of a patient-centered approach in cardiac rehabilitation, incorporating tailored interventions to address individual barriers to long-term adherence. Continued follow-up and support beyond the initial rehabilitation phase are key strategies to ensure sustained lifestyle changes. What are the potential risks associated with high-intensity interval training (HIIT) for patients in cardiac rehabilitation, and how should this type of exercise be incorporated into a rehabilitation program? Answer. While HIIT can offer benefits such as improved cardiovascular fitness and better patient outcomes, it carries potential risks for cardiac rehabilitation patients, including cardiac overload. High-intensity exercise places significant strain on the heart, which could provoke arrhythmias or ischemia in vulnerable patients. Increased risk of injury. Rapid, intense movements in HIIT may increase the risk of musculoskeletal injuries, especially for deconditioned or elderly patients. Inadequate supervision. Without appropriate monitoring, HIIT could lead to adverse events such as hypertension or severe fatigue. Incorporation into rehabilitation. Start with low intensity. For patients with stable coronary disease or those further along in their rehabilitation, HIIT can be incorporated gradually, starting with lower intensities and progressing based on individual tolerance. Close monitoring. Continuous monitoring of vital signs, ECG, and symptoms is essential to ensure patient safety during HIIT. Clear protocols. Strict protocols should be followed for determining when to modify or terminate the exercise based on physiological responses. What are the physiological mechanisms underlying the benefits of exercise training in cardiac rehabilitation, and how do these mechanisms contribute to improved patient outcomes? Answer. Exercise training in cardiac rehabilitation provides numerous physiological benefits that contribute to improved cardiovascular health and better outcomes for patients with heart disease. The key mechanisms include improved cardiovascular function, increased stroke volume. Regular exercise increases the heart's ability to pump more blood per beat, enhancing the stroke volume and overall cardiac output. Decreased resting heart rate. Consistent training improves parasympathetic tone, leading to low resting heart rate and reduced stress on the heart. Improved endothelial function. Exercise improves the function of the endothelial cells lining blood vessels, increasing vasodilation and promoting better blood flow, which is crucial for reducing vascular resistance and improving oxygen delivery to tissues. Enhanced oxygen utilization. Improved Vomax. Regular exercise enhances the body's ability to use oxygen more efficiently during physical activity, which is especially beneficial for patients with coronary artery disease. Increased mitochondrial density. Exercise increases the number and size of mitochondria in muscle cells, which enhances the muscle's ability to generate energy, reducing the workload on the heart. Improved lipid profile and metabolic health. Reduction in cholesterol levels. Exercise helps lower LDL cholesterol and triglyceride levels while increasing HDL cholesterol, contributing to better vascular health and a reduced risk of atherosclerosis. Improved insulin sensitivity. Exercise improves insulin sensitivity, which helps regulate blood sugar levels and reduces the risk of developing diabetes, a common comorbidity in heart disease patients. Reduction in blood pressure. Regular aerobic exercise helps reduce both systolic and diastolic blood pressure, especially in patients with hypertension. This decreases the overall workload on the heart and reduces the risk of heart failure and stroke. How does the presence of comorbidities such as diabetes, hypertension, and dyslipidemia affect the design and implementation of a cardiac rehabilitation program? Answer. The presence of comorbidities such as diabetes, hypertension, and dyslipidemia can influence the design and implementation of a cardiac rehabilitation program in several ways. Diabetes, blood glucose control. Exercise plays a significant role in managing blood glucose levels, but it may require adjustments in insulin or oral medications to prevent hypoglycemia. Foot care. Diabetic patients may have peripheral neuropathy or poor circulation, so exercises should avoid excessive strain on the feet, and daily foot inspections should be emphasized to prevent injury. Exercise modifications, depending on the severity of diabetes-related complications, e.g. diabetic retinopathy, certain high-impact activities may need to be modified. Hypertension, exercise intensity. While regular moderate intensity exercise can help lower blood pressure, it is crucial to avoid excessive exertion, especially in patients with uncontrolled or severe hypertension. Blood pressure should be monitored regularly during rehabilitation to prevent exercise-induced spikes. Aerobic and resistance exercise. Both types of exercise have been shown to reduce blood pressure, so a combination of aerobic exercises, e.g. walking, cycling, and light resistance training is often beneficial for hypertensive patients. Medications. Blood pressure medications, such as beta blockers or diuretics, may affect exercise response and should be considered when designing exercise programs. Dyslipidemia, lipid profile monitoring. Exercise can improve lipid profiles by increasing HDL cholesterol and lowering LDL cholesterol and triglycerides. Monitoring lipid levels should be part of the rehabilitation process to assess the effectiveness of lifestyle modifications. Exercise intensity. High-intensity exercise has been shown to be more effective in improving lipid profiles. However, it must be carefully tailored to the patient's fitness level, especially if they have other cardiovascular issues. Clinical implications. The rehabilitation team must carefully monitor patients with comorbidities and adjust their exercise plans and medication regimens accordingly. Discuss the benefits and challenges of implementing telehealth-based cardiac rehabilitation programs for patients in rural areas. Provide evidence-based recommendations to address these challenges. Answer. Benefits. Accessibility. Telehealth eliminates geographical barriers, enabling rural patients to access specialized care. Cost-effectiveness. Reduces travel and accommodation expenses for patients. Continuity of care. Allows for real-time monitoring and adjustments to rehabilitation plans. Challenges and recommendations. Limited internet access. Rural areas often face connectivity issues. Recommendation. Employ hybrid models, integrating local clinics for connectivity support. Patient engagement. Lack of technological literacy can reduce adherence. Recommendation. Provide training on telehealth platforms and user-friendly devices. Regulatory compliance. Telehealth must comply with HIPAA for data security. Recommendation. Use encrypted platforms to safeguard patient information. Relevant guideline. The American Heart Association (AHA) endorses telehealth for cardiac rehabilitation, emphasizing tailored solutions for rural and underserved populations. What are the primary considerations when setting glycemic targets for patients with type 2 diabetes undergoing moderate intensity cardiac rehabilitation? Answer. Pre-exercise glucose levels. Ensure glucose levels of 5.6 ml 100 mdl to avoid hypoglycemia. Adjust carbohydrate intake if levels are below this threshold. Intra-exercise monitoring. Monitor for symptoms of hypoglycemia, such as dizziness or fatigue. Recommendation. Patients should carry fast-acting glucose sources, e.g. glucose tablets. Post-exercise management. Risk of delayed hypoglycemia due to increased insulin sensitivity. Recommendation. Check glucose levels after exercise and adjust post-exercise meals. Relevant guideline. ADA standards of medical care in diabetes suggest individualized glycemic targets, emphasizing safety during physical activity. Mrs. Nguyen, a 65-year-old cardiac rehabilitation patient with a history of myocardial infarction, is prescribed a fitness tracker to monitor her daily activity levels. She reports that her wearable frequently alerts her to episodes of tachycardia, causing anxiety. What steps should her rehabilitation team take to address this issue? Answer. Device recalibration. Evaluate if the fitness tracker settings, e.g. HR thresholds, are appropriate for her condition. Patient education. Teach Mrs. Nguyen to interpret alerts appropriately. Emphasize that brief tachycardia episodes may not always indicate danger. Clinical assessment. Verify tachycardia episodes with a clinical grade ECG to rule out arrhythmias. Psychological support. Introduce stress reduction techniques like mindfulness or biofeedback. Relevant guideline. AHA guidelines recommend patient education and integration of wearable data into clinical assessments to ensure reliability. How can AI-driven predictive models improve outcomes in cardiac rehabilitation programs? Provide specific examples. Answer. Applications. Risk stratification. AI models can predict the risk of adverse cardiac events based on patient data, age, comorbidities, CG patterns. Example, predicting 30-day remission risk after myocardial infarction. Personalized rehabilitation plans and machine learning algorithms can optimize exercise prescriptions based on individual responses. Example, adjusting exercise intensity for patients with heart failure. Early intervention AI can identify subtle trends in wearable data indicative of worsening conditions. Example, detecting atrial fibrillation early using fitness tracker data. Relevant guideline. The European Society of Cardiology ESC emphasizes incorporating AI to enhance patient monitoring and personalized care. Describe evidence-based dietary interventions to manage both blood sugar and lipid levels in cardiac rehabilitation patients with type 2 diabetes. Answer: focus on glycemic control, low glycemic index foods, e.g. whole grains, legumes, reduce refined sugars, lipid management, increase intake of omega-3 fatty acids, e.g. fatty fish, flax seeds, limit saturated fats and trans fats. Combined approach, Mediterranean diet. Proven to improve glycemic and lipid profiles, incorporate high-fiber foods to delay glucose absorption and enhance satiety. A relevant guideline. The American Diabetes Association, ADA, and AHA advocate for combined dietary interventions to address overlapping metabolic risks. Compare the effectiveness of home-based cardiac rehabilitation programs to traditional center-based programs in terms of patient outcomes and adherence. Answer: home-based cardiac rehabilitation (CR) programs can achieve similar effectiveness to center-based programs in improving cardiovascular outcomes such as exercise capacity, physical function, and quality of life. These programs offer increased patient adherence due to their convenience and flexibility, as patients can engage in rehabilitation without the need to travel. Studies have shown improved patient satisfaction and better long-term adherence in home-based settings. However, a key challenge is lack of supervision. Remote monitoring technologies and wearable devices, e.g. CG monitors, are crucial for ensuring patient safety and tracking progress. Despite the benefits, patients may face challenges with self-motivation, potentially leading to inconsistent participation. For success, home-based CR programs should incorporate telehealth, regular virtual check-ins, and personalized plans. These measures can help bridge the supervision gap, ensuring safety and engagement while promoting long-term health improvements. Guidelines. The AHA and AACVPR support home-based CR as a valid alternative, recommending remote monitoring to maintain effectiveness and adherence. Why is integrating diabetes education into cardiac rehabilitation critical for managing patients with concurrent cardiovascular disease? Answer: integrating diabetes education into cardiac rehabilitation (CR) is essential because diabetes and cardiovascular disease (CVD) often coexist, sharing common risk factors like poor diet and physical inactivity. Diabetes increases the risk of CVD through atherosclerosis and endothelial dysfunction. Effective management of both conditions improves patient outcomes by addressing the underlying causes and reducing complications. By incorporating diabetes management into CR, patients receive comprehensive education on topics such as blood glucose control, dietary interventions, and exercise tailored to both conditions. This approach enhances the overall treatment plan, leading to improved cardiovascular health and better glycemic control. For example, patients learn how to monitor their blood sugar during physical activity to prevent hypoglycemia or hyperglycemia. Such integration also fosters long-term behavior changes, improving adherence to both exercise and medication regimens. This dual focus supports overall health and prevents further cardiovascular events. Guidelines. The AACVPR and AHA recommend this integrated approach, highlighting the importance of tailored education and management for patients with both diabetes and CVD to improve both cardiovascular and metabolic health. How do telehealth applications improve patient outcomes in cardiac rehabilitation? Answer: telehealth applications have significantly improved patient outcomes in cardiac rehabilitation (CR) by enabling remote monitoring and virtual rehabilitation. These technologies allow patients to engage in rehabilitation activities from home, overcoming barriers such as distance, mobility issues, and time constraints. Telehealth provides ongoing communication between patients and healthcare providers, ensuring that progress is monitored and adjustments are made to the rehabilitation plan. Remote monitoring tools, such as ECG monitors and wearable devices, track critical metrics like heart rate, blood pressure, and activity levels, providing real-time feedback. This ensures patient safety and promotes adherence, as patients feel continuously supported throughout the rehabilitation process. Additionally, telehealth reduces the need for in-person visits, which is particularly beneficial for patients in rural or underserved areas. Furthermore, telehealth facilitates personalized care, as rehabilitation programs can be adjusted based on continuous data from remote devices. Patients can also participate in virtual exercise sessions and receive online counseling, ensuring that their rehabilitation is not interrupted due to geographical constraints or health issues. How should healthcare providers manage glycemic targets for patients with diabetes during exercise to avoid complications? Answer: for patients with diabetes participating in cardiac rehabilitation, managing glycemic levels during exercise is crucial to avoid hypoglycemia or hypoglycemia. Hypoglycemia, low blood sugar, is a significant risk during physical activity, particularly for those using insulin or sulfonylureas. Healthcare providers should recommend that patients check their blood sugar before and after exercise. If blood sugar is below 100 mg/dL, patients should consume a carbohydrate snack before exercising to prevent hypoglycemia. On the other hand, hypoglycemia, high blood sugar, can occur if exercise triggers the release of stress hormones such as cortisol or adrenaline, especially in patients with poorly controlled diabetes. In such cases, exercise intensity may need to be adjusted or postponed if blood sugar is above 250/30 particularly if ketones are present in the urine, which may indicate diabetic ketoacidosis. Decare a personalized approach is essential, as each patient's response to exercise can vary. Monitoring blood glucose levels regularly allows providers to make real-time adjustments to insulin dosages, exercise intensity, or carbohydrate intake to maintain optimal glycemic control. How do wearable devices such as fitness trackers and ECG monitors enhance cardiac rehabilitation? Answer: wearable devices like fitness trackers and ECG monitors play a pivotal role in enhancing cardiac rehabilitation (CR) by providing real-time data on vital health metrics. These devices track heart rate, step count, activity levels, and electrocardiograms (EGs), allowing for continuous monitoring during both exercise and daily activities. This data is transmitted to healthcare providers, enabling remote supervision and personalized feedback. The use of wearable devices in CR programs leads to improved patient engagement by providing instant feedback and allowing patients to set personal fitness goals. By tracking physical activity and heart rate variability, patients can better understand their physical limits and progress, promoting a sense of accomplishment and motivating adherence to rehabilitation protocols. Additionally, wearable ECG monitors help identify irregular heart rhythms, providing early warnings of arrhythmias or other cardiac events, thereby increasing patient safety. These devices allow clinicians to adjust rehabilitation protocols promptly, ensuring that patients are exercising within their safe heart rate zones. What are the key components of the DASH dietary approaches to stop hypertension diet, and how does it help in managing hypertension in cardiac rehabilitation patients? Answer: the DASH diet is specifically designed to help manage hypertension and improve heart health. The key components include high intake of vegetables and fruits. These provide potassium, magnesium, and fiber, which help regulate blood pressure. Low-fat dairy products provide calcium and reduce saturated fat intake. Whole grains serve as a source of complex carbohydrates and fiber. Lean proteins includes fish, poultry, and plant-based options like beans and nuts, which reduce red meat consumption. Limited sodium intake recommends a sodium intake of less than 2,300 mg day, or ideally 1,500 mg day for those with high blood pressure. Low in saturated fats and cholesterol reduces the risk of atherosclerosis. How it helps: reduces systolic blood pressure by 814 mHg in hypertensive patients, improves lipid profiles, and reduces the risk of cardiovascular events. Explain the significance of informed consent in cardiac rehabilitation, especially when dealing with vulnerable populations such as elderly patients or those with cognitive impairments. Answer: informed consent is a critical legal and ethical requirement in healthcare, ensuring that patients are fully aware of and agree to the procedures and treatments they will undergo. It is particularly significant in cardiac rehabilitation for vulnerable populations due to the following reasons. Autonomy respects the patient's right to make decisions about their care. Understanding: patients must comprehend the benefits, risks, and alternatives of the proposed treatment. Competency: vulnerable populations may face challenges in understanding due to cognitive impairments. In such cases, a legal guardian or family member may provide consent. Efforts must be made to communicate in an understandable manner, possibly using visual aids or simpler language. Legal framework: under HIPAA, Health Insurance Portability and Accountability Act, providers must also protect the patient's health information while obtaining consent. Failure to ensure informed consent may result in ethical violations and legal liabilities. Case study: Maria, a 55-year-old Hispanic woman recovering from a myocardial infarction, is beginning cardiac rehabilitation. She expresses concern about the sodium content in her traditional meals, which include soups and stews that are culturally significant. Question: what approach should her cardiac rehabilitation specialist take to address Maria's concerns while respecting her cultural preferences? Answer: the cardiac rehabilitation specialist should culturally tailored education, explain the importance of sodium reduction in managing hypertension and preventing further cardiac events, use culturally relevant examples to illustrate low sodium alternatives, modify traditional recipes, suggest using fresh herbs, spices, and lemon juice instead of salt, recommend low sodium broths for soups and stews. Patient empowerment: teach Maria how to read nutrition labels to identify low sodium options, provide cooking demonstrations that adapt traditional recipes. Collaborative goal setting: involve Maria in creating a meal plan that honors her cultural values while aligning with dietary goals. Discuss the role of omega-3 fatty acids in cardiac rehabilitation and the recommended intake for patients. Answer: omega-3 fatty acids, primarily EPA and DHA found in fish oil, play a crucial role in cardiac rehabilitation. Cardioprotective effects: reduce triglycerides by 2.50%, decrease inflammation and platelet aggregation, lowering the risk of thrombosis, improve endothelial function and reduce arrhythmic events. Sources: fatty fish such as salmon, mackerel, and sardines. Plant-based sources like flax seeds and walnuts provide AI, which can convert to EPA and DHA, though less efficiently. Recommended intake: American Heart Association (AHA) recommends at least 2 servings of fatty fish per week, about 500 mg daily. PA DHA. For those with elevated triglycerides, up to 4 grams day of omega-3 supplements may be prescribed under supervision. Dr. Williams, a cardiac rehabilitation professional, suspects a breach of confidentiality when he notices that patient records are accessible to unauthorized staff members at his clinic. What steps should Dr. Williams take to address this ethical and legal issue? Answer: Dr. Williams should secure the records, immediately restrict access to the patient records to authorized personnel only, report the breach, notify the compliance officer or privacy officer as mandated by HIPAA, implement safeguards, conduct staff training on confidentiality and secure handling of records, ensure access controls such as passwords and encryption are in place, notify affected patients. If a breach has occurred, inform patients as required under HIPAA's breach notification rule. Audit systems: conduct regular audits to prevent future breaches. Failure to act could lead to legal penalties and loss of trust. How can fiber consumption benefit cardiac rehabilitation patients, and what are the recommended daily intake levels? Answer: fiber is crucial for cardiac health due to its cholesterol lowering, weight management, and blood sugar regulating properties. It comes in 2 types. Soluble fiber: found in oats, barley, beans, apples, and citrus, it binds bile acids in the intestines, reducing LDL cholesterol. Soluble fiber also slows glucose absorption, helping manage blood sugar vital factor for patients with diabetes and heart disease risk. Insoluble fiber: found in whole grains, nuts, and vegetables like carrots, it promotes healthy digestion and prevents overeating by enhancing satiety. Recommended intake: the dietary guidelines for Americans recommend 25 grams day for women and 38 grams day for men. Older adults over 50 should aim for 21 grams day for women and 30 grams day for men. For cardiac patients, fiber-rich diets reduce the risk of secondary heart events by lowering cholesterol and maintaining healthy body weight. Introducing fiber gradually alongside adequate water is crucial to avoid digestive discomfort. Regular monitoring ensures adherence and dietary optimization, reducing the risk of complications associated with heart disease. Raj, a cardiac rehabilitation patient, struggles with meal planning because he frequently eats out due to work commitments. Many of his meals are high in saturated fat and sodium. What strategies should his rehabilitation team recommend? Answer: Rod's team should focus on realistic strategies tailored to his lifestyle. Smart choices: Rod should select grilled or baked dishes instead of fried ones and request sauces or dressings on the side to reduce calories and sodium. Menu awareness: he should choose restaurants offering nutritional information and prioritize low sodium or heart-healthy meals, such as salads with lean proteins or soups without added salt. Portion control: suggest ordering smaller portions, sharing meals, or saving part of the meal for later. Meal preparation: encourage Rog to meal prep for work, occasionally integrating easy-to-carry, heart-healthy options like salads, whole grain wraps, or fruit. By balancing dining out with homemade meals, Rog can effectively manage his cardiac health while maintaining his work commitments. This aligns with the American Heart Association's guidance for sodium and fat reduction in a practical setting. What are the primary ethical considerations in maintaining patient confidentiality during cardiac rehabilitation, particularly under HIPAA regulations? Answer: maintaining patient confidentiality is a cornerstone of ethical practice and is mandated by the Health Insurance Portability and Accountability Act (HIPAA). Under HIPAA, healthcare providers must protect patient health information from unauthorized access, use, or disclosure. Key considerations include secure data handling. Ensure all patient records, whether digital or physical, are stored securely. Digital records must be encrypted, and access should be restricted to authorized personnel. Physical records must be locked in secure locations. Minimal disclosure principle. Only disclose the minimum necessary information to perform specific tasks. For example, when sharing progress reports with other healthcare providers, limit information to relevant clinical data. Informed consent. Obtain explicit consent from patients before sharing their information, except in situations of public health reporting or emergencies permitted by HIPAA. Addressing breaches. If a breach occurs, it must be reported promptly to the patient and relevant authorities, as required by HIPAA's breach notification rule. Training and awareness. Staff should undergo regular training on confidentiality protocols to mitigate risks. Confidentiality builds trust, ensuring patients feel safe sharing sensitive information crucial for effective rehabilitation. Violations can result in legal penalties and undermine patient care. How does the DASH diet specifically benefit patients undergoing cardiac rehabilitation, and what are its core principles? Answer: the dietary approaches to stop hypertension. DASH diet is designed to lower blood pressure, a critical goal for cardiac rehabilitation patients. It is rich in nutrients that support heart health, such as potassium, calcium, and magnesium, while being low in sodium, saturated fat, and cholesterol. Core principles: emphasize whole foods, incorporates fruits, vegetables, whole grains, and low-fat dairy products. These provide essential nutrients like fiber and antioxidants, which reduce inflammation and improve vascular health. Limit sodium. Recommends limiting sodium intake to 1500-2300 mg to manage blood pressure effectively. Healthy fats. Focuses on healthy fats from nuts, seeds, and fatty fish while avoiding trans fats and excessive saturated fats. Moderate protein. Encourages lean protein sources like poultry, fish, and legumes. Portion control. Guides patients on appropriate serving sizes to prevent overeating. Maria, a 67-year-old cardiac rehabilitation patient, is hesitant to engage in physical activity due to fear of exacerbating her condition. She has no current symptoms but a history of a myocardial infarction. What steps should her rehabilitation team take to address her concerns and promote safe exercise? Answer: Maria's reluctance is common among cardiac patients, and her team must address it with empathy and education. Risk assessment. Conduct a comprehensive evaluation, including stress tests and medical clearance, to determine her exercise capacity and identify any risks. Education. Explain the benefits of exercise in cardiac rehabilitation, such as improved cardiovascular efficiency, reduced anxiety, and enhanced quality of life. Highlight that structured programs are tailored to prevent overexertion. Supervised exercise. Start with supervised sessions under the guidance of a cardiac rehabilitation specialist. This includes low-intensity activities like walking or cycling on a stationary bike, gradually increasing intensity. Personalized plan. Develop a plan that aligns with Maria's fitness level, preferences, and medical history. Emphasize warm-ups, cool-downs, and proper hydration. Psychological support. Address her fears through counseling or peer support groups. Sharing success stories from similar patients can encourage her to participate.